Hi everyone, I'm Teresa. I'm a digital health researcher from the University of Melbourne, and we come from the Centre for Digital Transformation of Health. So our goal at the Centre is to stop developing and delivering digital tools that don't work. And that's because we've seen too many examples of tools that failed, and we talked a lot about this during the panel discussion. And it's not because the technology is flawed, but because they weren't designed and tested with end users in mind, or they failed to consider diverse needs of patients and clinicians, especially in under-resourced settings. And that brings us back to the theme of this session, which is really, without a digital equity lens, even the most ambitious digital health programs can collapse. And when they do, it means wasted energy, wasted time, and a lot of money as well. So this highlights why we need to evaluate digital tools early, in realistic settings, and with a good representation of users. This is partly because, unlike drugs, there is no standard development pathway for digital health. And one way to do that is through clinical simulation, which is my research focus, and that's why this is more of a methods-focused presentation, and a little bit about its application in a project that we're currently planning using AI Scribes for older adults in rural and regional Australia. So let's start with what clinical simulation is. Maybe just a quick show of hands of who's heard about what clinical simulation is. Okay, great. We have a good number. It's long been used to train clinicians in a range of knowledge and skills, but in the context of digital health, simulation means enacting realistic clinical scenarios with potential users. And this can happen in a simulated intended environment or in situ. For example, we can have it in a clinician consultation room or a hospital ward or a patient's home. And we would also have the clinician and or the simulated patient or carer, whoever the intended end users are, interacting with a digital health tool themselves, depending on whether this is a clinician or a patient-facing tool. And this happens in the presence of researchers. And researchers could be fly on the wall, or they can observe through one-way glass if available. And that helps the researchers to understand how the tool is being used within the intended context. And then following that, the researchers will debrief with the participants afterwards to probe further on the behavior. So for example, you looked a little bit confused when you're interacting with this tool. Why was that? So really, simulation allows us to generate evidence through some of these, but not limited to observing how end users interact with the tool in its intended context, identifying usability issues and workflow fit, measure time efficiency. For example, if there is a tool that works really great, but then it takes double the time to use it and it doesn't fit within the usual care. And then we can probe them and gather feedback on trust, usefulness, and value. So for example, do they like it? Do they find it easy to use? Do you actually think this is a solution? Like, is technology the solution for the problem that you're facing? Or do we agree that this is even the problem that you're facing in daily life? And also, any other facilitators embarrassed to using this tool for them and their colleagues. It really helps gather evidence quickly, and it allows us to change the tool, iterate them before real-world implementation, which would lead to an improved final product, which will then help with the technology being able to be adopted and also more effective. And it is also increasingly recognized by regulatory bodies like the US Food and Drug Administration for making market authorization decisions for software as a medical device. So, why does it matter for equity? Simulation is especially valuable when we're working with priority populations, so people who are underrepresented in digital health design and testing, such as, for example, older adults or people in rural and regional areas, those from culturally and linguistically diverse backgrounds, indigenous community LGBTIQ plus communities, neurodivergent individuals, people with physical and intellectual disabilities. And we don't have to recruit a lot of them, but a few consumer representatives who would speak on behalf of the community, so advocates. And sometimes one consumer representative may also wear a few different hats, and they act as critical friends, helping us to assess whether a tool is really inclusive and responsive to the needs of the community. All right, so let's dive into the project a little bit. So across the Australian healthcare system, clinicians are facing an escalating crisis of admin load. And recent studies estimate that primary healthcare clinicians, nurses, and allied health professionals spend more than 40% of their time on documentation and compliance-related tasks. And that's happening often outside of scheduled hours or pajama time without dedicated support. And in rural and regional settings, this is compounded by infrastructure gaps and also workforce shortages. So some facts about rural and regional health in Victoria. About 25% of Victorians live in rural and regional areas, and these areas cover about 87% of Victoria's landmass, with communities spread across vast distances. So imagine being the 1 in 4 living in 87% of the landmass versus the 3 in 4 living in the 13% of the landmass. And fun fact as well, this is something I Googled today, Victoria is the second smallest state in Australia, but the size of that is about the size of the UK, the whole country. So community nurses need to travel up to 2 hours between patient homes. That's and so about like from 9 to 5, you can probably just visit 3, 4 at max. From a previous study, we also heard concerns around implementing remote patient monitoring from hospital clinicians and staff, saying that they've got 35 different cultural and linguistically diverse communities in the region, and like, how do we manage these language differences? In terms of health outcomes, rural Victorians experience higher rates of chronic diseases, and they also face higher rates of preventable hospitalizations and mortality, often due to delayed access to care. And this is actually one of the strongest motivations for the project I'm about to share with you. For the digital connectivity and challenges, many rural areas suffer from poor internet and mobile coverage, which affects access to telehealth and digital health services. Clinicians report that telehealth consultations also often fail, because connections is not reliable and patients have to move from one room to another, and some patients just don't have the plan or the devices needed for that. So this is a quote from a focus group that we had. Are they in black spot area? Do they have internet? Do they even have landline? All right, so I have 2 minutes, so I've really got to fly this through. The proposed solution is that we have ambient AI scribes to help with documentation workload and to enhance clinical communication. But even with international studies suggesting that these actually can work, it may reduce documentation time, improve note completeness, and enhance clinical experience, the integration is poorly understood and not tested in rural and regional settings. And there's a call from the Australian College of Rural and Remote Medicine for such technologies to be tested, giving a warning that urban-centric AI solutions often fail to reflect the realities of rural care. So the aim of our study is to respond to the priorities by using simulation. And so we'll evaluate the use of a commercially available ambient AI scribe system, starting with transcription-only configuration mode. And this is going to be used for research purposes only. And we'll be conducting this with real clinicians from rural and regional health services in Western Victoria, one at a time. And including scenarios that are designed to reflect common rural consultation challenges. So, I think, so the kind of data we're looking at includes the quality of the AI scribe, the workflow challenges, security concerns, and any other facilities and barriers, and support or training needs. And hopefully, by the end of this, we are able to create implementation guidelines and evidence to support responsible, scalable adoption of AI, Scribes in rural and aged care settings. Great, thank you. Question?